Hello everyone. Hello, Dr. Nilesh. I'm on fire, I think. I don't know. Okay. Yes, I have a couple of them messages. I have yours cross message. I have Siddhant's message, which I haven't replied. I have replied a couple of them. Just give me some time more. I will reply everyone. And yes, Dr. Siddhant, I have taken your questions as well into account. So you will see those changes. We will do it. Actually, I'm planning to put whatever has been changed recently as a different file itself, like a miscellaneous file, so that because I know everybody is doing from the elements, but whatever recently has been updated or the answer has been changed, better is to I compile it in a file so that no one has to go over back and forth again and again. They can just see that miscellaneous file and just get updated. Okay. Now with that, you have mini mock this week. Yes? No?
Not sure, but
The mini mock is this week itself, and the discussion is on this Sunday. Is everyone aware of it?
it wasn't announced on the WhatsApp group.
It's given in your LMS as well. The mini mock schedule.
Probably others. I'm not sure, doctor.
Hello everyone. I can't hear anyone actually.
Good evening, ma'am.
Yes, good evening. Yes, so you guys know, right? The mini mock is this week.
Yes, ma'am.
Yes, for everyone. If you're not looking back in the schedule, then I will let them know to announce it so that you're aware of it. Mini mock is towards the end of the week, this week itself, and then you have the discussion on this coming Sunday for your mini mock, and then next week onwards you have your full mocks.
Ma'am, can you please ask the team to upload the video recordings for mock by tomorrow? So then,
Yes, they will upload it. They will upload it. Yes.
yes, ma'am. I texted them on Saturday, Friday evening, and they're still saying that it won't be possible by tomorrow.
Is it? Because I know they have uploaded the mock.
Yes, ma'am. They're saying day after tomorrow, but from day after tomorrow, the mini mocks and mini mocks are starting.
Okay. I will check with them what else I can do to speed it up. But still it's okay. At least it is solved. Okay. Because mini mock is I think over 2 days. And mini mock is not that many questions. You won't take that much of time to solve it. Okay. Now let's go to the Parmac quiz and the video quiz. So I think the Parmac quiz one, which you already have in your LMS. I hope everybody has done it. And even the recording part. Now this is like towards the end we are coming. So it's like therapeutic guidelines towards the end. So it's all about analgesics, patients with medical conditions, and your anti-anxiety medications. So basically, combination of that in your Parmac part. Now, see, Jasmine, a 32-year-old female, attends your dental practice for the surgical extraction of her lower impacted third molar. She has no significant medical history. She is not pregnant and is not on any regular medication. You plan to prescribe analgesics for post-operative pain control. She has no known allergies and reports moderate pain on day one post-op. 32-year-old, she attends your general dental practice for the surgical extraction. No significant medical history and she is not on any medications as well. You plan to prescribe her analgesics for post-operative pain control. She has no known allergies and reports moderate pain on day one post-op. Now, which of the following is considered first-line therapy for managing mild to moderate dental pain post-operatively? What should be the first-line therapy for mild to moderate dental pain? Okay, Dr. Deena?
Yes, doctor. I will go with option A.
Option A, ibuprofen 400 to 600 mg every 6 to 8 hours.
Yes.
Right? No doubt with that. Because that is given as your first line therapy for mild to moderate dental pain. Codeine. Do we even give codeine?
No.
No.
No. Okay. So it is not at all given. Oxycodone comes into picture when you have
Severe pain.
severe pain. Okay. Paracetamol with tramadol combination. Paracetamol with tramadol combination can be given for what?
Moderate to severe pain.
Yes. Aspirin 500 mg every 4 hours.
Not given.
Not given. So definitely here ibuprofen 400 to 600 mg every 6 to 8 hours. Now going.
If we also have another option saying paracetamol 1000 mg every 6 hours.
Yeah, but first line therapy is NSAIDs. If you don't have any indication, you start with NSAIDs. But if you have anything, then it will change, like something given in your medical history, then it will change to your paracetamol then.
Okay, ma'am.
Okay, because let's open up TG as well so we can have a quick glance at it. Uh,
Okay. Okay, let's open up this part. This is like a revision as well for you guys from your teaching. So if you can see already, it is mentioned here about your NSAIDs are preferred for acute non-subacute dental pain because they are anti-inflammatory. Can you see my screen?
Yes, doctor.
Okay, because they're anti-inflammatory, their adverse effect profile limits their use in some patients. Before prescribing NSAIDs for a patient, determine whether the use is appropriate based on their comorbidities and risk factors. So that's what we say, like medical conditions, and is there any risk factor with them? If its use is appropriate, then ibuprofen is always preferred because of good efficacy with limited toxicity and widespread experience with its use. However, other NSAIDs have different safety profiles and may be preferred in some patients. Now, if I move to this table as well, if you see here, uh, analgesic regimes for mild to moderate acute dental pain in adults. So definitely your NSAIDs and paracetamol should be taken regularly rather than as required. If adjunct analgesia is required for mild to moderate acute, then you combine it. Ibuprofen 400 mg orally 6 to 8 hourly for the shortest duration possible, no more than 5 days without review, plus paracetamol 1000 mg orally 4 to 6 hourly. Now, avoid fixed dose combination products because they do not allow the daily dose of each drug to be maximized. So, we don't try to give any combination product here. Secondly, if a COX-2 selective NSAID is preferred based on the patient's risk factors, wherever you cannot give ibuprofen, then you can go for your celecoxib, that is 100 mg orally twice daily for the shortest duration, plus paracetamol 100 mg orally 4 to 6 hourly. Okay. Then, if these are contraindicated, if you cannot give celecoxib as well, then you just rely on your plain paracetamol. Okay. Even let's go and check for your severe as well. For your severe, what you do is you basically give patients NSAIDs as a three drug regime, ibuprofen, or you can give a COX-2 selective, that is your celecoxib, plus paracetamol, plus oxycodone, which is immediate release 5 mg orally every 4 to 6 hours as necessary for the shortest duration possible, no more than 3 days. Use a lower dose in elderly or frail patients because they are particularly vulnerable to adverse effects. In patients who cannot use NSAIDs, use paracetamol plus oxycodone. Okay, so I think that part is clear. Let's go back to our questions. Okay, now Jasmine reports a history of gastric ulcer. Which of the following would be the most appropriate analgesic option? Now we know she has gastric ulcer. Now this is like a caution for us. Now, if I have to prescribe an analgesic for her mild to moderate pain, what should I go for? Uh, Ibuprofen with omeprazole because omeprazole is like it's protected from the gastric ulcer, and ibuprofen is good for mild to moderate pain. Okay, anyone else wants to try? Yes, Dr. Siddhant.
Ma'am, paracetamol.
And why?
Ma'am, ibuprofen with omeprazole, it's not mentioned in TG, aspirin we don't have. And celecoxib could be considered, but I think paracetamol would be a safer option.
Celecoxib is what?
Non-selective COX-2 inhibitor.
Yes. So can we give that or not?
Yes, ma'am, we can give that too.
We can give that too, but then again, there is a caution here, right? When you say about celecoxib, prescribing celecoxib alone, on top of it, we are not 100% sure whether we can go for COX as well or not. Because while prescribing that as well, we have to take into account, we have to talk to the medical GP or the specialist who is treating the patient. Now, in this case, the safest or the most appropriate would be paracetamol. You have no issues with paracetamol, right? So definitely, most appropriate analgesic option will be your paracetamol alone. Now, omeprazole. We are not treating the patient here for gastric ulcer, right? So definitely, we are just talking about the dental aspect. We are just talking about the dental aspect. On top of it, if I go back to your therapeutic guidelines itself, Okay, let's open up this. Now, this is from your TG itself. Recognize patients at increased risk of gastrointestinal toxicity. Avoid NSAIDs, that is your Nurofen, diclofenac, naproxen. Then they say use a COX-2 selective. And if a COX-2 selective cannot be used, use paracetamol alone. Now, the problem was this question did not mention about much information regarding whether we can use celecoxib or not, right? So, definitely the safest here to mark would be our paracetamol alone. Clearly, it says use paracetamol alone for mild to moderate pain. Okay, now going towards the table that everybody should know should be patients who should not be prescribed NSAIDs by a dentist, patients with a severe kidney impairment, severe heart failure, and active gastrointestinal ulcer, so Nurofen cannot be given, or gastrointestinal bleeding, patients with bleeding disorders, patients taking corticosteroids, or anticoagulants. You might have questions regarding patients taking prednisolone or patients taking warfarin. Please remember, like they will not specify there, but then they will ask you just a simple question, what analgesic can be given. That's the reason this is very important to remember. Kidney impairment, heart failure, gastrointestinal ulcer or gastrointestinal bleeding, bleeding disorder, corticosteroid or anticoagulants, patients with multiple risk factor. Example, elderly patients with a history of gastrointestinal bleeding. Okay. Now moving back to the question. So here your answer is paracetamol alone. Now, which analgesic combination provides a synergistic effect in severe dental pain? This should be easy. Just now we saw when we were reading about mild to moderate and moderate to severe. Yes, Dr. Siddhan.
Ma'am, option D, ibuprofen plus oxycodone.
Okay. Please don't take into consideration the previous question, because the question here says if Jasmine reports a history of gastric ulcer. Right now, many must be thinking, then why are we giving ibuprofen again? But the question is not asking with relation to the patient. The question is just a plain question asking which analgesic combination provides a synergistic effect in severe dental pain. It's just a plain generalized question. And the answer is yes, ibuprofen plus oxycodone. Because if you see the other combinations, ibuprofen plus paracetamol is for your mild to moderate. So it doesn't work. Aspirin we are not giving. Codeine we are not giving. Right? Naproxen plus paracetamol is again for your mild to moderate. Now moving to the next one. What is the maximum daily dose of paracetamol in an adult with normal liver function?
4 grams.
4 grams? And you have one more question, something like this in your Parmac quiz 1. Anyone remembers?
Toxic
Your,
dose.
let me open up your Parmac quiz 1 as well.
Dr. Raj,
Yes,
what's the normal dose in a patient that has liver cirrhosis for paracetamol?
liver cirrhosis.
Yeah. If you have to prescribe paracetamol, because the question is for a normal liver function. If there's a abnormal,
Liver function. Okay, good question. Just give me 1 second. I'll open up here.
okay.
See, I'll open up the article itself. Paracetamol in patients with pre-existing liver disease. This is from your. It again talks about the safety of paracetamol use in this patient is an important issue because paracetamol is commonly used, effective, and readily available. Liver disease and alcohol dependence are both relatively common conditions. If there were a significant problem with therapeutic doses of paracetamol in patients with pre existing liver disease or alcohol abuse, then this would be a major public health issue. Additionally, alternatives to paracetamol, including your NSAIDs, carry their own risk of adverse effects. Now, what they have mentioned is the retrospective case reviews and case reports such that as mentioned describe hepatic injury after repeated paracetamol ingestion with therapeutic intent, although usually not a therapeutic dose. In addition, the information contained in this report is often incomplete and contradictory. History of ingestion is often unknown or contradicts other clinical information provided. What they are trying to say, the history may indicate a therapeutic dose, but the serum paracetamol concentration recorded can only be produced by ingestion much larger than the history would indicate. Because your liver is compromised, so removal and metabolism will be decreased here. In contrast, there are no prospective studies in humans that show an increased risk in these patient groups. So Benson administered 4 gram per day paracetamol or placebo for 13 days in patients with stable chronic liver disease in a double-blinded and detected no clinical deterioration or abnormality of liver function test. So the thing is, yes, can be given, okay, but there is a caution. Okay, so that's what they're saying here. Therefore, this trial supports the safety of short-term use paracetamol in patients with stable chronic liver disease or alcohol abuse. All good. And let me just open up the previous as well. You can see on my screen. This was the question related to how many tablets of 500 mg paracetamol should be taken, right? Should the patient take in a single time to exceed the toxic dose? That's your 10 gram, right? This is the question.
Yes, ma'am.
Okay, all good.
Ma'am, can you
And
also go to question number 22 and 23 from this page?
okay, just give me 1 second. Question number 22.
23. Or we can take it at the end.
Yes, let's take it at the end. Let's first finish up our normal pharma quiz. Okay.
Yeah.
It's just that I am trying to bring up those questions as well so that you have a memory of what we are doing, what is the maximum dose, what is the actual dose that you are giving, so that we remember those things because one or the other question is definitely going to come in your exam. With your paracetamol, yes, you tend to have either of the questions. Now, which of the following statements regarding opioids for dental pain is true? So they're asking you which of the following statements regarding opioids for dental pain is true.
D. Opioids carry a risk of dependence and should be used short term only.
Yes, that's a
Because
correct
they
answer.
do. Yeah.
Yeah. So A says codeine is more effective than Nurofen. Now, if codeine would have been more effective than Nurofen, then definitely the first line would have been codeine, but then we don't use codeine at all. Oxycodone should be first line in surgical pain. Again, oxycodone should be first line in surgical pain. If you see your therapeutic guidelines as well, it starts from Nurofen. Oxycodone is introduced when you suspect that yes, your surgical procedure can cause severe pain to the patient, and then you introduce oxycodone. Opioids are recommended for long term dental pain management, no way, because you're just prescribing opioid for 3 days only. On the prescription, it shouldn't be more than 3 days. If it is written by a dentist for more than 3 days, then the pharmacist usually gives you a call and nullifies the prescription. They won't give the medication. On top of it, again, you cannot write on the same prescription opioid and dexamethasone, that is a steroid, together. You have to give separate prescriptions. Opioid carry a risk of dependence and should be used short term only. Yes, that is correct, right? That's the reason we are giving it only for 3 days and then reviewing the patient that why the patient needs it. Tramadol is recommended for all dental patients. Again, this is wrong. The true statement here is option D. Next scenario is Michael, a 40-year-old man, is extremely anxious about undergoing a root canal procedure. He has a history of generalized anxiety disorder managed with sertraline and no known drug allergies. He does not smoke or drink alcohol, which is good. You consider prescribing a short-term anxiolytic. Okay. Now, 40-year-old man, extremely anxious, undergoing root canal procedure, has a generalized anxiety disorder. See, in this question, they have given you that he does not smoke or drink alcohol. What is the issue if he would have been drinking alcohol? How do you manage a patient who drinks an alcohol and then you are going to consider a short-term anxiolytic?
We cannot give benzodiazepine.
Yeah, so what do you advise the patient?
Don't take alcohol for last 24 hours.
Perfect. See, this is one of the question that has been come, and this is again from your anxiolytic part. In your slides as well, it is given. Please make sure you go through it. I will just open this up. Because see, things are changing with ADC as well. They can bring up new questions. New questions are not actually a new questions. Everything is there in the books. So, what are you advising the patient actually? So this is the advices given. This is patient's assessment for anxiolysis. When do we consider that the anxiolysis should be considered for this patient? The nature of the patient's anxiety, patient's medical, surgical, dental, and medication histories, including allergies, patient's cardiovascular, respiratory, and airway status, patient's exercise tolerance or functional status, patient's social circumstances, including intake of alcohol or other psychoactive substances. Okay, so these are first you are trying to consider all these things. You are assessing whether this patient is suitable to give or not. And then they have given you patient groups at increased risk of adverse outcomes: children younger than 2 years, elderly or frail patients, patients with severely limiting heart, cerebrovascular, lung, liver, or kidney disease, obese patients, obese patients, patients with significant obstructive sleep apnea, patients with a known or suspected impediment to endotracheal intubation, patient with a history of gastrointestinal bleeding, particularly if associated with cardiovascular compromise or shock, patients with severe anemia, patients at risk of aspiration, and patients who had previous adverse events due to anxiolysis. The next part, which is here, what instructions. Before the appointment, you can have a light meal on the day of your appointment, but do not have anything to eat or drink within 2 hours of your appointment. Do not drink alcohol or use illicit or recreational drugs on the day of your appointment. This is important. Okay, if you are taking other medicines, take them at the usual time unless otherwise advised. If you are having an oral medicine for anxiolysis, it will need to be taken at the dental clinic approximately 1 hour before your treatment starts. It has to be taken at the dental clinic. So patient comes in the dental clinic 1 hour before, he takes the medication in front of you. Wear loose fitting clothes and do not wear jewelry. Remove contact lenses. Let your dentist know if you are unwell on the day of your appointment because it may affect your treatment. Again, after the appointment, stay at the clinic until you have recovered. You must be escorted home by a responsible adult and supervised for 24 hours. Rest and do not undertake strenuous activities. If you are hungry, you can have a light meal. Avoid hot food and drinks because your mouth will be numb. Do not drive or operate machinery for 24 hours after the appointment. Do not drink alcohol after the appointment as well. Do not drink alcohol or return to work, make important decisions, or sign important documents until the day after your appointment. So that is like 24 hours they are talking about. Okay. So please remember, and going back again to the question. So here he is not smoking or drinking. So easy. We are considering to give him a short-term anxiolytic. Now, which of the following is a contraindication to prescribing benzodiazepines for anxiety? Just now we have seen.
It's severe hepatic impairment.
Perfect. It's severe hepatic impairment, right? We have just now seen. So, if a patient has a severe hepatic impairment, yes, is a contraindication to give benzodiazepine. Patient taking SSRIs, yes, you can give. History of epilepsy, yes, can be given. No prior exposure, that is also fine. Dental phobia, yes, that's the reason you're considering. Now, what is the recommended oral dose of diazepam for adult dental anxiety? So, what is the recommended oral dose for diazepam for adult dental anxiety? What is answering?
It's 5 to 10 milligrams.
So this is again from here. Diazepam 5 mg orally 1 hour before the procedure. Minimum requirement is definitely 5 mg. Okay. So in your options, you have 2 to 5 and you have 5 to 10. So how do we go about it?
We'll go with 5 to 10 because the minimal is 5.
Is 5, exactly. So 5 to 10 is a better option here. Lorazepam is 1 mg orally 1 to 2 hours before the procedure. Oxazepam is 7.5. Temazepam is 10 mg. Okay. Diazepam is 5 mg orally 1 hour before the procedure, administered at the dental practice. For adults at increased risk of outcomes, we have already seen. Okay. Okay. Next is, which statement regarding benzodiazepine use in dental practice is true? So if I'm trying to prescribe benzodiazepines, which statement among this is true?
They impair the psychomotor skills and driving ability.
Yes, that's the reason we usually advise not to drive when you have taken this medication. Now, they can be used long term for patients with chronic anxiety. Can they be used for long term for patients with chronic anxiety?
No.
Think about it. Can they be used long term for patients with chronic anxiety? People come to you in clinics who are having a generalized anxiety, right? How do they manage their anxiety? Come on, everyone. Okay. Do we prescribe diazepams for patients who have generalized anxiety? Does the GP prescribe them as a long term use?
No, ma'am.
No, yes.
No.
Then how do they manage their anxiety? Who generally have a lot of anxiety issue.
Ma'am, other drugs like
Yeah,
SSRI,
other drugs,
maybe SSRI,
and
therapy, PCS.
okay. Now the question is regarding dental practice. Okay, with your generalized anxiety, if you talk about patient going to a GP and getting a medication, yes, many people are on a very low dose of benzodiazepine who have generalized anxiety. That's why I asked you about this first option. They can be used long term for patients with chronic anxiety, but not in a dental practice. Because when you are talking about which statement regarding benzodiazepine use in dental practice is true, then we are talking with respect to our dental treatments, which is like a one off. We don't prescribe them for a long term. We just prescribe them 1 hour before the procedure. That's it, right? We just want to handle that procedural anxiety what they have. But if you talk about, because this question was purely with respect to a dental practice, otherwise, on a norm, a patient having a normal generalized anxiety, you can see they might be taking a very low dose every day. That's another reason. Sometimes you get patients who are on Valium, but they are on a very low dose of Valium. So this option A, is not related to our dental procedure. Option B says they are safe to prescribe to pregnant patients. Are they safe to prescribe to pregnant patients?
No, ma'am.
No, that is way clear. They impair psychomotor skills and driving ability, which is true, right? That's how it works. They should be taken with alcohol? No. They are metabolized renally?
No, ma'am. By liver.
Then by liver. Okay. So if they are metabolized by liver, right, and if a patient have a liver issue, will we consider giving him a benzodiazepine?
No.
Then what should we consider giving him?
Nitrous oxide.
Perfect. That's a variation of the question that you might get with a liver cirrhosis question. And I think a liver cirrhosis question is there in your ADC bank as well. So this is the variation you might get with anti anxiolytics basically. The question is regarding to this because it is metabolized in liver. So what kind of sedation you would consider for the patient, and the nitrous oxide would be best for such a patient. Please make a note of it because yes, you can expect such a question in your exam. Moving to the next one. Michael is anxious even after diazepam. He requests IV sedation. Which of the following professionals is legally authorized to provide conscious IV sedation in Australia? And this is from your policy of conscious sedation, which is under 6 point something, maybe 22 or 23. I don't remember the exact, but in that range only it is there. So this is from that policy. Yes, Dr. Siddhant.
Ma'am, option C.
Perfect. Now, Michael is anxious even after diazepam and he's requesting IV sedation. Who can do an IV sedation? The question is which of the following professionals is legally authorized to provide conscious IV sedation in Australia? General dentist with 5 years of experience. You have 5 years experience, you have 10 years experience, you have 20 years experience. But unless and until you're not endorsed with AFRA, you have not taken a proper training, you don't have that certification, you cannot do conscious IV sedation. Any dentist with first aid training? No. First aid training is a different training which is related to BLS and ALS, basic life support and advanced life support, and how to manage a normal medical emergencies in the clinic. It is not related to conscious IV. A dentist who completed additional sedation training and holds a sedation endorsement. This is the exact statement given in the policy as well. Okay. So even if you have 1 year of experience here, but if you have done that training, that particular training, and you are endorsed, then you can go and provide conscious IV sedation. Dental hygienists cannot, even under supervision, they cannot. Okay. GP with no dental qualifications, again, this is not related here, and he cannot. He has, even with a GP, if they are giving, they have to be endorsed. So, a dentist who completed additional sedation training and holds a sedation endorsement is the person who is authorized to provide you conscious IV sedation. Okay. Now, the next scenario is John Smith is a 65-year-old man who attends your dental clinic for scaling and root planing. His medical history includes mechanical aortic valve replacement. Okay, this is not a valvular defect and this is not about a septal defect. This is a mechanical, that's mechanical is in relation to your prosthetic. Okay, mechanical aortic valve replacement 5 years ago, type 2 diabetes, and well controlled hypertension. He is not allergic to penicillin. He is due for full mouth periodontal debridement involving subgingival instrumentation. Okay, so you are going to do a full mouth perio debridement involving subgingival instrumentation. Okay, so let's see what is the question. According to current guidelines, should John receive antibiotic prophylaxis before the planned dental treatment? Let's first see, does the treatment requires it? Because there are two things, the medical condition and the treatment, right? The treatment is subgingival instrumentation. If I'm going subgingivally, antibiotic prophylaxis is needed or not needed?
Yes, it's needed because inducing bleeding, which means like going into the blood vessels.
Yes.
So
According
it's
to the therapeutic
needed.
guidelines as well, perfect. Manipulation of gingival tissues. That particular terminology. Please remember, manipulation of gingival tissues. So we are going subgingivally, right? So definitely I will need for the procedure. Now let's see, for this particular condition, do we need it? Mechanical aortic valve replacement. Does this condition falls under that table where we say that the patient should need antibiotic prophylaxis?
Yes, because it is an artificial heart valve.
Perfect. So I'm going again in your therapeutic guidelines. You can revise it here one more time. This table everyone has to remember. In what conditions we consider giving antibiotic prophylaxis? Okay. What are the conditions? Prosthetic cardiac valve. Now this was, the name was given as mechanical aortic valve. Mechanical is basically talking about a artificial, a prosthesis which is present, right? So prosthetic cardiac valve, including transcatheter implanted prosthesis or homograft. Please remember, this is transcatheter implanted prosthesis. This is not a implantable electronic device, which is different. Okay? Because see, if you see this sentence, this person definitely needs. But here, endocarditis prophylaxis is not recommended for patients with forms of valvular or structural heart disease not listed in this box, including patients with mitral valve prolapse, septal defect, or cardiac implantable electronic devices. So these patients will not need. Okay. Prosthetic cardiac valve, including transcatheter implanted prosthesis or homograft, yes. Prosthetic material used for cardiac valve repair, such as annuloplasty rings and cords. Then third is previous infective endocarditis. This is 3PCR. Prosthetic cardiac valve, prosthetic material, previous infective endocarditis history, congenital heart disease, but only if it involves unrepaired cyanotic defects, repaired defects with residual defects, rheumatic heart disease. Rheumatic heart disease, I have already mentioned you. It has been updated by them. Rheumatic heart disease in any individual, not in high risk patients. Okay, rheumatic heart disease is actually considered as an independent risk factor. No matter it is a patient, normal individual, or a group who is socioeconomically low. In anyone, if you have this rheumatic heart disease, yes, he will need antibiotic prophylaxis. Okay, now going back to our question. So we clarified the procedure needs an antibiotic prophylaxis, and also the medical history which has been provided to us also indicates that this patient needs. When both these boxes stick together, only then we go for antibiotic prophylaxis, right? Now option A says yes because he has a prosthetic heart valve, which is correct. No, because diabetes increases the resistance. No, diabetes is not related here. Okay, so all these options are nullified straight away. We just have to look for two boxes, that is the conditions and what procedure you are doing. Supposedly, see, the same patient comes to you and I have to do just a class 1 composite restoration. Do I need to give any antibiotic prophylaxis for this patient?
No, not in that case.
Perfect. So we have to match up the procedure and the condition both. Okay. Now, moving to the which of the following is the first line antibiotic prophylaxis for John, assuming no penicillin allergy? Yes, Dr. Siddhant, you can answer this question and then you can ask your doubt as well.
Ma'am, amoxicillin 2 grams orally 1 hour before the procedure.
Perfect. Yes. And what was the doubt?
Ma'am, I saw a question somewhere regarding antibiotic prophylaxis, like in which of the procedure antibiotic prophylaxis is needed. And I was confused between two options. One of them said composite
Yes.
restoration, and second said supragingival scaling.
Okay, I think the same question Aryan had sent me. We will go see. I actually replied Aryan as well for this because you have been just mentioned as what is the safest procedure we can do in that particular kind of patient, right? Now the thing is, I don't have a scenario. First thing first, so we don't know exactly any intraoral picture anything is provided or not. Now with your composite restoration and supragingival scaling, with your supragingival scaling, definitely if the picture is not provided, I'm assuming that there is no bleeding on probing gonna happen, like no bleeding is gonna happen, right? But supposedly, if there is any calculus fleck, right? Supposedly there is any calculus fleck, yes, it looks supragingival, but it tends to go subgingival. Then the safest to be marked in that situation would be composite restoration. But then again, if this question comes with an X-ray, with an intraoral picture, and that composite restoration is something like a subgingival restoration you are going to perform, supposedly class 2 going subgingivally, then composite restoration wouldn't be that safe. Then I would mark supragingival scaling. So it again depends on how the question is presented and what other information is provided. Otherwise, if it's just like this question, then I would go for composite restoration.
Okay, thank you.
Okay? Yes, Dr. Aryan.
Doctor, when we place a rubber dam, we place a rubber dam clamp. Can that
Yes.
rubber dam clamp cause infective endocarditis in such patients because we are impinging on these gingival sulcus?
Yes.
And so
Yes, but that's the reason composite restoration cannot be considered always that you are going to place a rubber dam. Rubber dam is mandatory only and only for root canal treatment. You can do composite restoration with cotton roll isolation.
Even class 2s,
Yeah.
class 2 and class 5.
You can.
Okay.
Unless and until you really want to put a rubber dam, because as per the guidelines, rubber dam is mandatory when you are doing a root canal procedure, right? Because the safety is the biggest issue here, right? Now with your class 5s or veneers or class 2 restoration, yes, if you want to get a very good restoration, if you are working on the aesthetic part as well, many people, yes, use rubber dams, but not rubber dam is mandatory for a restoration procedure.
But ma'am, we also use a wedge and matrix system for class 2.
Yes, that's what I said, Siddhant. That's what I said. If the question would had been given information regarding that I'm going to perform a class 2 restoration, which is going subgingival, something like that, then my composite restoration wouldn't be safest in that. So it should come up. When you say composite restoration, we don't know. And when you talk about composite restoration as well, first thing first, when you will come to part 2, you will learn when we place our matrix band, right? The matrix band shouldn't be impinging on the gums. So that is first thing they check in your OSCEs, that is skilled OSCEs, how you have placed your matrix band. Because if you are saying there is a 0.5 mm clearance from the gums, supposedly you are performing a class 2, not every class 2 is going subgingival, right? Actual class 2, if you talk about, there is a clearance from the gum level. So your matrix band should be above the gum level. Even when you talk about the wedge is not impinging more on your gums unless and until you are going towards your posterior part, because there you have broader contacts. But as you come forward, you will actually keep your wedge a little higher because you keep it only exactly under your contact point. So this question is just as a question given to you. In that case, definitely I'll go with composite, but usually such question comes with scenarios and some kind of more information regarding subgingival restoration or this or some X-ray. Then it's easier to mark. Okay.
Yes, ma'am.
All good. Now, which of the following is the first line antibiotic prophylaxis for John, assuming no penicillin allergy? Now, we have done this part clearly. If the patient has no penicillin allergy, the choice is our amoxicillin, 2 gram orally 1 hour before the procedure. If amoxicillin is contraindicated, if the patient would had been penicillin allergy, what would had been our answer? If the patient would had a penicillin allergy, what would had been our answer?
Clindamycin.
Clindamycin 600 mg orally 1 hour before the procedure, right? What is the therapeutic dose of clindamycin?
300 mg thrice a day.
Perfect. Clindamycin 300 mg thrice a day is the therapeutic dose. 600 mg orally 1 hour before the procedure is prophylactic dose. What is the dose of celecoxib?
100 mg.
Just
100 mg.
100 mg how many times?
Twice a day.
Twice a day. Right? Okay. Because one or the other question will come. So just make sure you revise that part as well. Moving to the next one. If John were allergic to penicillin, which of the following would be the most appropriate alternative? We have just now done this part. So I'm not taking this. This is clindamycin, which we already know. Which of the following procedures does not typically require antibiotic prophylaxis, even in high risk cardiac patients? This should be easier.
Yeah, taking dental radiographs, D.
Okay. So taking dental radiographs does not require any antibiotic prophylaxis. Okay. Subgingival scaling, we just now discussed. Periodontal flap surgery, yes. Extraction of third molars, definitely. Incision and drainage of abscess, yes. You are manipulating gums. So all this will need. Taking dental radiographs, no. Taking dental impressions, do we need? If we are taking
No.
alginate impressions, no. Right? Okay. Now, if I'm doing a crown prep in this patient, will that treatment need
Yes, ma'am.
an antibiotic prophylaxis?
Yes, ma'am.
Yes. Why?
Ma'am will be doing a gingival retraction.
Perfect. Okay. So variations of the question. Because if you are doing a crown prep, you will be placing a cord, retraction cord. So definitely this patient will need antibiotic prophylaxis. Yes, Dr. Siddharth.
When we do a 6-point periodontal examination, we have to give antibiotic prophylaxis. What about
Yes.
the initial periodontal exam?
Initial periodontal exam, in that when you are trying to do probing, if the patient needs probing, initial examination, when you say I can see the patient, right? I can see the patient's come and all, and then I can decide if this patient needs a perio examination, then definitely I won't be performing the perio examination until and unless he takes the antibiotic prophylaxis. Then we can do his periodontal probing.
Okay, ma'am. So in general, if we are doing a periodontal examination, we need antibiotic prophylaxis.
Yes.
Okay.
Now, which of the following is a valid reason to withhold antibiotic prophylaxis in a high risk patient? When I don't give. Basically, this question means when I don't give antibiotic prophylaxis.
The procedure does not involve gingival
Gingival
manipulation.
manipulation. Perfect. So, because see, sometimes the questions are easy, but it's the language of the question, and definitely for many of us, English is not the first language, so they get stuck with the wordings. So that's why I told that this question actually means where we don't need. It's a valid reason to withhold antibiotic prophylaxis in a high risk patient. Now, the procedure involves soft tissue only. If the procedure involves soft tissue, do we need to give antibiotic prophylaxis or not?
Yes, because we're manipulating the gingival, or we're getting into the bloodstream basically if we're going into the soft tissues.
Very good. B option says the patient had antibiotics within the last month. Even if the patient had antibiotics within the last month, and if your procedure warrants for antibiotic prophylaxis, I will be giving. I cannot withhold for that reason. Now, the procedure does not involve gingival manipulation, then I don't need. So I definitely don't need to give. The patient had infective endocarditis prophylaxis, which is the third P in your table, right? So he needs. The patient is taking antihypertensives. Is it a reason to withhold antibiotic prophylaxis?
No, ma'am.
No. This is something like a patient comes to you, a cardiac patient, right? And you want to prescribe him antibiotic prophylaxis, but you see that he's taking antihypertensives. Do we stop giving antibiotic prophylaxis even if he needs? No. So definitely that is not the answer. But yes, we don't need to give antibiotic prophylaxis if I'm not manipulating the gums. Now, which of the following is true regarding prophylaxis and prosthetic joint replacements?
Um, it is B, only patients within the first 6 months, because with the joint replacement we care about the 6 month line.
Okay. So anyone else?
Oh, okay.
Option D, doctor.
And whom I'm talking to?
Bhagirath.
Hello, Dr. Bhagirath. How are you?
I'm good, doctor. How are you? Long time.
Yeah, I'm good, good. Okay. Yes, option D, prophylaxis is not recommended for any patients with prosthetic joints. As per your Australian guidelines, we no longer give any antibiotic prophylaxis for any patients having any prosthetic joint issue, right? That is your hip or knee replacements. That has been taken out way earlier. So, patients with prosthetic joints always require antibiotic prophylaxis is wrong. Only patients within the 6 months of joint replacement need cover. Again, this is wrong because, as per the guidelines, no prophylaxis is not at all needed for any patients with prosthetic joints. Okay. C says patients with prosthetic joints and diabetes require routine antibiotic prophylaxis. No, both of them doesn't. Dentist must consult the orthopedic surgeon before all dental treatment. No, it has been taken out. Okay, so we no longer require any antibiotic prophylaxis for the prosthetic joint issue. Now the next scenario is Sarah Walker is a 22-year-old patient who presents to your dental clinic for a planned extraction of tooth 3-6 under local anesthesia. Okay. She has a history of rheumatic fever and is on long-term intramuscular benzyl penicillin every 28 days for prophylaxis. Okay. She has no known drug allergies and is currently well. She has a history of rheumatic fever and she takes a long-term benzyl penicillin every 28 days. Okay. Now she has no drug allergies and she is coming to you for a planned extraction of tooth 3-6. Based on Sarah's medical history, does she require antibiotic prophylaxis before the extraction?
Option D.
And why?
A patient with history of rheumatic fever, they always need prophylaxis.
Yes, everyone?
Yes, doctor.
Now, in your TG, it is clearly given rheumatic heart disease, right? Rheumatic fever can lead to a rheumatic heart disease or can be an early indication of a rheumatic heart disease. So, definitely in your rheumatic fever cases as well, we will give antibiotic prophylaxis. Okay, so option D is correct here. Yes, because of her history of rheumatic fever. Next is given that Sarah is taking a long term benzyl penicillin, which antibiotic is considered appropriate for prophylaxis? Because now she is been taking it as a long term. prophylaxis every 28 days, what prophylaxis I should give her just before the dental procedure? She's already taking benzyl penicillin. Yes, Dr. Siddhan.
Ma'am, amoxicillin.
Sorry, which one?
Amoxicillin.
Amoxicillin, yes. And why?
Ma'am, there's a paragraph mentioned in the last page of TG medical part.
Perfect.
It says that if the patient has been on benzyl penicillin, there's no need to change the choice for antibiotic prophylaxis. But
Very
if
good.
the patient has recently taken the same antibiotic like amoxicillin for a short time previously, then we have to modify our choice.
Perfect. So, in patients taking long-term benzyl penicillin for prevention of recurrent rheumatic fever, evidence suggests that amoxicillin susceptibility of viridin streptococci in the oral flora is not significantly affected by your benzyl penicillin prophylaxis. So, amoxicillin is appropriate for endocarditis prophylaxis in this setting. Okay. In contrast, if a patient is taking or who have recently taken a course of beta lactam, that means someone who has taken recently 3 days, 5 days before, evidence suggests that amoxicillin may be affected. So, a non beta lactam antibiotic such as clindamycin should be given as a prophylaxis. Okay, let's go back to our question. So, yes, here I can give this patient amoxicillin. Okay. Even if she's taking benzyl penicillin every 28 days for her rheumatic fever, I can give. Okay. The next question is, if instead Sarah had completed recent 7-day course of amoxicillin for sinusitis 4 days ago, what would be the best option for antibiotic prophylaxis now? So if she has recently done, what would be the best?
Option D, clindamycin.
Option D, clindamycin, right? There's no doubt for that. Now, what is the recommended adult dose of clindamycin for endocarditis prophylaxis? Again, similar question we have done already.
Option C.
600, yeah.
600 mg 1 hour before the procedure. Okay. Now, why is amoxicillin not recommended for infective endocarditis prophylaxis in patients who recently completed a beta lactam course? Just now we read that part as well. Does it increase any bleeding risk? Does it? Does your amoxicillin relate to any bleeding risk here? Does it either generally lead to any bleeding risk? No. Does it causes cross reaction with your LA? No. It may not be effective due to reduced susceptibility of oral flora. Now, what they're saying, it is not recommended for infective endocarditis prophylaxis in patients who recently completed a beta lactam. That means, like the previous question, if she has taken already for sinusitis, why I can't give her amoxicillin again as a prophylaxis? Because if she has taken it recently, then definitely it will not be effective because already your oral flora is susceptible now. It's already taken that amoxicillin for 4 days. So again, if you are providing amoxicillin as a prophylactic, it will not work. That's the reason they say, okay, if you have recently taken amox and if I have to give a prophylaxis, then I have to switch to clindamycin. It is contraindicated in patients with rheumatic fever, which is wrong. It increases gut microbiota disruption, which is again wrong. Okay, so your correct answer is C. So you can see the all questions were related to your analgesics, anxiolysis, and antibiotic prophylaxis. Okay, so Parmac will include all this part. So let's move on. I think that's the last slide. Okay, let's take a short break, a 10-minute break, and then we continue with our pedo.